Thalassemia Welfare Society. So without wasting much time, I invite Dr. Arora to update us on the burden of thalassemia in Delhi. Dr. Arora, please.
Thank you, madam. I'll first of all like to thank. I'm not able to share this PPT. Please allow me.
Not able to share. Huh? Stop कर दो. Stop
Post.
share. Yes.
I'm not able to share.
You
yes.
Now you will be able to. Now you will be able to.
Yes. Thank you. So first of all, like to thank Dr. Deepika Deka, your DJ Form, and all the organization of Obs and Gynae, all the organizers, for giving me a chance to speak on the topic of from the core of the heart, that is thalassemia. I will be very direct to speak. First of all, forgive me if I have some things which are not favorable to gynecologists, because I have to speak on those terms. So I'll just a minute. I'll share you a few stories. This is 1995. There's a family having a thalassemia major male child. After some time, the boy's maternal aunt, that Masi, got pregnant, and she informed her gynec that she had a nephew who is a thalassemia major. The gynec said, "You are quite healthy. There is no need for thalassemia test." The lady's real sister, that is the mother of the thalassemia major, she intervened and forced the gynec to get the test done, telling her, "We don't want another thalassemia major in our family." The gynec takes the sample and asks the lady to come after 1 week. After 1 week, the gynec told that the reports are normal. The lady delivers a male child diagnosed thalassemia major at 3 months of age. And the new thalassemia major not welcomed the family and was not transfused. The child succumbed to the disease within 1 year. So I like to give you a message: the strong family history of thalassemia is, and not screening a thalassemia is a crime. Again, in 10 years later, in 2005, a 28-year-old gentleman approaches me to inquire about thalassemia. He was diagnosed as thalassemia carrier in a screening camp organized by our society few days back in the MNC he was working. His wife was already 4 months pregnant. She also turned out to be thalassemia trait. Referred to AIMS for prenatal diagnosis. Fetus turned out to be thalassemia major. By the time the termination could be planned, the lady had crossed 20 weeks of gestation. Somehow, she got the termination done at this stage, taking risk to her life. The irony of the story is that the husband has seen our advertisement in the newspaper on International Thalassemia Day just few days back and asked her gynec to test for thalassemia status. But the gynec had refused her on the ground that there is no history of thalassemia in their family. So, family history of thalassemia is not a prerequisite to screen for thalassemia. Again, 10 years later, 2015, a young lady becomes pregnant in October 2012. She visited gynec 1, G1, immediately after missing period. G1, gynec 1 advises hemoglobin, urine, HIV, and ultrasound, etc. She did not have facility for delivery. So the patient shifted to other gynec during first trimester only, which had who had nursing home attached. G2 advises some more routine investigations. At 8 months of pregnancy, because of low hemoglobin, the lady was advised HPLC. The lady turned out to be a thalassemia trait. Since it was an advanced stage of pregnancy, no steps could be taken. The lady delivers a beautiful girl in June 13. And June 14, the girl turned out to be thalassemia major. So don't miss to screen for thalassemia during first trimester. Whenever a lady visits you, please screen the lady during first trimester. Okay, just one slide on what is thalassemia. It's an adult hemoglobin is formed by the 2 alpha and beta globin genes. In thalassemia, the synthesis of either alpha or beta chain is reduced. In beta thalassemia, there is defective synthesis of beta chain, and the manifestations are due to excessive alpha chains. While in alpha thalassemia, alpha chains are reduced and excess of beta chains cause reduced survival. Alpha thalassemia is of two types, alpha plus and alpha zero. Alpha plus is mild and its inheritance is of not much importance. Alpha zero is severe. In India, alpha plus is more common. Since in our country, beta thalassemia is very common, hence when we term thalassemia, it denotes only beta thalassemia. So there is a big thalassemia syndrome, alpha thalassemia, beta thalassemia, sickle cell, HBE, HBC, D, and HBQ, etc. What happens in thalassemia? When the child is born, at the time when you deliver a child is normal, hale, and hearty at birth. By 3 months to 2 years, child starts showing symptoms of severe anemia, and treatment includes repeated blood transfusions, investigations, hospital visits every 2 to 4 weeks, and costly medicine throughout life. The cost of therapy is 50,000 to 2 lakh per year. And fear of transfusion, transmitted infection, hepatitis B, C, HIV. There's a loss of time, energy, money, endocrine complications, liver, heart failure, always fear of early death. And you know the permanent cure is the stem cell transplantation, which is not achievable in all due to non-availability of bad donor, high cost, and high risk involved. So prevention is the ultimate cure. Thalassemia is not a disease of few people. 50,000 million people are thalassemia carriers. 5 crore Indians are thalassemia carriers. And one of the most celebrated is Amitabh Bachchan is also thalassemia carrier. If a person like him, who is at age of around 80, is so active and much more than all of us, if he can be a thalassemia carrier, anybody can be a thalassemia carrier. So how common it is? Beta thalassemia is 1 to 17% in different communities, average is 4%. Around 10,000 to 12,000 thalassemia major are born every year in our country. Sickle cell is more common in tribes and as high as 40% in some areas. HBE is highly prevalent in West Bengal and Northeast states. Alpha thalassemia is not significant. In Delhi, 1 out of 18 is a thalassemia carrier. And around 200 thalassemia major are born every year in Delhi. And 1 thalassemia major child is born every 45 minutes. Means by the time you finish this session, we'll have another thalassemia child. Why there is a need for prevention? Because there's a lifelong repeated blood transfusion, lifelong frequent hospital visits, lifelong costly treatment, and the limitations of permanent cure. Around 1,875 crores are required to treat approximately 1.5 lakh thalassemics, and over 40% voluntary blood is used by thalassemics. Ignorance is highly prevalent in both public and medical professions. By prevention, you reduce the burden of patients, families, as well as the government. So once a thalassemia major is diagnosed, family starts pursuing obstetricians. I'm sorry to say, but this really happens for not advising thalassemia tests. And here I would like to quote what Dr. Sharda Jain said just recently. We are advising blood group and HIV to everyone. Say HIV is just 0.25% in India, while thalassemia is 4%. We fail to understand that HIV, which is 1 in 400, is advised to every pregnant woman, and which is 4 in every 100 is not advised. This you all know, this is autosomal recessive inheritance. When both husband and wife thalassemia carriers, then in each pregnancy, 25% chance of having a thalassemia major child, 25% absolute normal, non-limited thalassemia carrier, and 50% thalassemia carrier like parents. And if one of them is not a carrier, then child will never be a thalassemia major, 50% carrier and 50% normal. So in each pregnancy, there is 25% risk to offspring if both parents are thalassemia carriers. I like to show some international success stories. Cyprus, Sardinia, Greece, Italy, Thailand, many countries have controlled thalassemia. If you see Cyprus started thalassemia control program in 1974. Within 10 years, it brought to almost just 1%. They control up to 99% in 10 years. While in Italy and Greek, they control up to 90% in 10 years. And the reason behind was the most successful control programs are based on carrier detection, counseling, and fetal diagnosis. So how to screen thalassemia? So very, very easy. Any physician can diagnose thalassemia screening. See, whenever you ask for a hemoglobin test to any lady, be it a young girl, adolescent girl, any anemic lady, or just for any routine infection, you always ask for CBC. If you look into MCH, MCV, RBC count, and hemoglobin, if you look into all these 3-4 parameters, you can easily suspect that the person is thalassemia carrier. MCV less than 80, MCH less than 27, and especially if RBC count is higher in comparison to hemoglobin. See, when hemoglobin is low in iron deficiency, and RBC will also be low. But in thalassemia carrier, RBC count will be high. RTW will be normal in thalassemia carrier unless until it has concomitant iron deficiency anemia. So the final test is HbA2, direct HbA2, Hb electrophoresis, or HbHPLC. If it is more than 3.5%, the person is thalassemia carrier. So thalassemia test needs to be done just once in lifetime. So why not get it done even at the age of 5 years, 6 years, 10 years? When be it a boy or girl, whosoever, maybe in your case, maybe it also girls, when she comes for any other reasons, you can ask for HbA2 test at that time. See, here I like to put one more thing. See, you are doing blood group test. Okay, blood group is required by the gynecologist for if it is turns out to be Rh negative. In otherwise, blood group is done usually when the child goes to school at 3 years of age. I fail to understand it is required either at the pregnancy when it is negative or a blood transfusion. See, 1 in 1,000 doesn't require blood transfusion. And if at all anybody requires transfusion, it is not done just like a filmy style, taking blood from one person, giving to other. Whole battery of tests are done, which takes at least 2 to 3 hours. So all these tests are done. Why not blood group kind test? A test which is not required by 99% people is done at 3 years of age only because the teacher has told. That to a KG teacher, not even a higher secondary or primary teacher. And a test which is required by everyone in the life. Everybody is going to marry and have children. And that is not done even at the time of the pregnancy. So if you go if it is less than 3.1% HbA2, it is normal or maybe alpha thalassemia trait. If it is 3.1 to 3.9%, it may be beta thalassemia trait with iron deficiency anemia or interaction of alpha and beta thalassemia. So if you find HbA2 between 3.1 to 3.9, if at all you are not suspecting beta thalassemia, go for mutation, because 3.2, 3.3 may be silent beta thalassemia. So you should advise for mutation analysis if it is less than 3.5. Don't say it is not a carrier. 3.9 to 9% beta thalassemia trait, and if it is more than 9%, it is HbE. So what are the fallacies while diagnosis thalassemia carrier state? Concomitant iron deficiency lowers HbA2. If you see it is very severe anemia, severe iron deficiency, then you can give 1 month iron therapy or 2 month iron therapy, adequate iron therapy, and HbA2 level will rise. But don't pay this thing in pregnancy. In pregnancy, if you doubt, go for mutation analysis. Silent BTT may not have elevated HbA2. Same case I am telling you. Coexistent alpha thalassemia may have normal level of HbA2. Delta beta thalassemia may have normal or low level of HbA2. So if you're slightest of the doubt, then go for mutation analysis by gene sequence. This is the most important slide. I request all of you to please concentrate. What we have been facing day and night, that when a lady goes to, you have seen 3 cases, and even today, if a lady has a hemoglobin of 11.5 gram, mostly people say, no, you cannot be a thalassemia carrier. If you have a 11 gram hemoglobin, you cannot be thalassemia carrier, which is totally wrong. Go for MCV, MCH value. If MCV is less than 80, MCH less than 80, even a male with 11.5 to 15.3 may be thalassemia carrier. Even female having 14 gram hemoglobin may be thalassemia. Never say if you have a hemoglobin 13 gram, you cannot be carrier. Please take out from this mind. I'll give you 2 examples as well. Here, this is one case where this hemoglobin is 11.5 gram. MCV is 88, MCA 28, and HbA2 is 2.3%. That means the person is not a thalassemia carrier. And the other case you see, hemoglobin is 14.2 gram, MCV is 61, MCA is 20, and A2 is 5.3, and the person is thalassemia carrier. You see, 14.2 is a carrier, 11.5 is not a carrier. So never go by hemoglobin value. At least look for MCV and MCH. Now we are getting in all CBC investigation these to be done. So carrier state has no disadvantage. No, you are not. It is not frightening to get tested thalassemia carrier. It should not be considered as a stigma. Risk arises only when both partners are thalassemia carriers. Homozygous state is very severe and eventually fatal with limited curative possibility. So fetal diagnosis is always available and safe. Fetal diagnosis, sorry. So who holds the master key? I think Dr. Sharda said, sorry, Dr. Smita. She said that yes, we people, I would say gynecologists, obstetricians, they are the key persons who hold the key. So obstetricians, please advise thalassemia carrier when the time when lady is most receptive to honor your advice. This is them. See, this is the only branch of medicine where the family is ready to spend anything. They are not going to ask you any question. Many times we have seen that obstetricians saying that if we ask for this test, they will say you're increasing our cost. I have never seen a family that the poor or rich, if you ask 10 tests, they are going to do it. If you ask 20 tests, they will not refuse it. You ask for 10 ultrasounds, they are not going to refuse it. Then why they will refuse the HPLC? Never. So please do ask for HPLC to each and every pregnant woman when they visit you. So what is how to screen? Screen the pregnant woman on first visit. If screening is positive, confirmed by HbA2 estimation or Hb electrophoresis HPLC of the husband. If husband is not a trait, no further action requires. If husband is trait, there is a need for prenatal diagnosis. If fetus is major, the family has the option to abort it, which is legal. And if it is normal or thalassemia trait, continue the pregnancy. So what are the indication of partner screening of pre-diagnosis? See, if in your case, I'm saying, if the lady is a beta thalassemia trait, delta beta trait, sickle trait, E trait, D trait, D thal or Q thal, the partner should be screened. And prenatal diagnosis is required if both are beta thalassemia trait, one is trait, other is HBE, hetero or homo. One is trait, other is sickle. Both are sickle and HBD trait or homozygous, delta beta trait, beta thal major, or beta delta and beta thal major. So all these conditions require prenatal diagnosis. And the conditions where it is not prenatal diagnosis not required, if both partners are HBD trait or homozygous, both are HBE trait or homozygous, or one partner is HBQ India and other beta thalassemia trait. But I like to reiterate that HBQ India with sickle required diagnosis. Q with beta thal doesn't require, but Q with sickle requires. So you all know that how to go for prenatal diagnosis. CVS, amniocentesis, chondrocentesis, and pre-gestation.
Discussing.
Yes, that's it. So So what is the generally cost factor involved? In Delhi, it's Loknaik Hospital, it is zero, no cost. Anybody can come and have it. Everything is free. In AIMS, SGPJ, Lucknow, PJ, Chandigarh, around 2,000 to 4,000. In private, it varies at different centers, 20,000 to 40,000. And PGD, you know much better. I'm not aware of it. Maybe 3 lakh to 4 lakh or so. So these are few thalassemic children. What I want to request is please, please, please take appropriate action and with all your fellow colleagues so that we don't have this much number of thalassemia patients. Because thalassemia tests need to be done just once in lifetime. That is the single message I like to give you. So there is old saying that the inferior doctors treat full-blown cases and mediocre doctors treat to prevent complications, and superior doctors like all of you treat to prevent the disease. Thank you. And it is it is a teamwork. See, everybody, all physicians, all medicals, paramedicals, society, NGOs, government, everybody has to work. But the most important role has to be played by the obstetricians and gynecologists, you people. Thank you very much.
Thank you very much, Dr. Arora. It was really a brilliant presentation. I think all of us are much wiser now, especially diagnosis and suspecting thalassemia even in a women who are not anemic. Because by and large in India, most of the obstetricians accept that hemoglobin of 10 or 11 gram % is quite okay for a pregnant woman. So normally we do not act. And screening for thalassemia can be done by a simple test like a CBC. If we order, it comes in nowadays with an automated analyzer. Every report has an CBC. We just need to take efforts to read those values, that's all. And in a government setup like ours, like a Maulana Azad, we have a NESTOP, which is used quite frequent as a routine for screening all pregnant women. So our obstetrician only have to take care that we just write that the woman has to undergo and check if she has undergone or not. All Delhi government hospitals do NESTOP as a free of cost test for all women. So thank you so much for updating us on this topic. I don't believe there is.
I'll have to one more comment, please. See, another problem what we have been facing. See, in thalassemia major, we don't give iron. So some people, maybe even let it be obstetricians, especially for you people, I'm saying is, many obstetricians, what they do, they stop iron therapy to pregnant women, which is not true. A pregnant thalassemia carrier should be given as much iron as you give to any other lady. Iron therapy is not contraindicated to thalassemia carrier person. So you can give iron to every pregnant woman as much as you give to other ladies.
Thank you so much for that addition. Another point I would like to add for all obstetrician colleagues, please do the tests at the first visit, because even if we do HPLC and diagnose thalassemia trait, we need to diagnose the mutations if we have to offer them the prenatal testing. So that timelines have to be kept in mind, because in our country with the MTP Act, every fetal medicine expert is running after the timelines. So it should be done at the first visit. Don't wait till the hemoglobin report comes. If it is low, then I will advise HPLC or a thalassemia testing. I don't see any questions in the chat box. Dr. Sharda, madam, your expert comments, please.
Please unmute yourself, madam.
Ma'am, please. Ma'am, you are muted. We can't hear you. Sharda, ma'am, you are muted. Yeah.
No. Both husband and wife, it should be done. If they have not been screened earlier, both husband and wife should be done. The wife may not be thalassemic trait, but if the husband is, at least 50% children will be thalassemic, will be having a thalassemia trait. So I get it done as a policy at our center. Both husband and wife at the first antenatal visit, we get it done. And as Dr. Arora has said, simple test, CBC. If you're clear about these two things MCV and MCH. So simple. But that was news to me, people like me used to think, if your hemoglobin is more than 12 gram %, you will not be thalassemia minor. But it is an eye opener for me.
Just yesterday, I saw a case referred by Dr. Arora, thalassemia major. Her hemoglobin was 11.
No, madam, something we have to really act. If the other countries, small countries can do it, we can also do it.
Absolutely.
Madam, it
Can
is
we
just
go on to the next topic?
as you're doing OGT on the first visit, I think make it mandatory from your folksy and whatever organization you have. So like OGT, it should be made on first visit mandatory.
Yes. Thank you so much. Thank you, ma'am. Thank you, Dr. Arora, for that presentation. And if there are no questions, is there something in the chat box?
We can go on to the panel, and we have time at the end of the session.
Yeah. So we close this session and over to the Dr. Leena for the subsequent sessions.
Yes. Thank you so much.
Can we stop sharing the slide? We go on to the next.
Ma'am, we have moved to next.
Okay.
Thank you, ma'am, and thank you, sir, for such an eye-opening session. I think sir has made it very clear to all of us how important it is to study thalassemia. So now we would like to start the next session, which includes the panel discussion.